validated tests available to assess the anxiety, to history of depression. The psychology comes into relation to their positioning, finances, whether they are working. So, like for example, in Australia, if you are talking about athletes, they at the higher elite level, they are they are streamed to specific clubs. But if you go to a one tier lower, they are actually working as well. So the athlete has a lot of pressures. So specific answer to the question is there is no direct correlation to the incidents. However, this is one of the most important things to look into when you are assessing sports injuries.
Thank you, sir. The next question is, has simulation modeling approach applied to studies in throwing injuries by Utkarsh Singh?
Now, when you talk about simulation modeling in throwing injuries, I think it all comes down to assessing what's going on in the labs. And there have been so many studies in throwing injuries, specifically when you have that simulation things going on. The challenge is how do you put that practice onto the field? But short answer to your question is yes. But again, how do you exactly measure on the field when there are a lot many other factors going on as a team approach? But there is always an attempt to, I was listening to Andrew yesterday when he was talking about training the cricketers in South Africa with specific technique. So similar to that, probably I will extend that thing to throwing as well, that you do extend that approach to the throwing injuries as well.
Thank you, sir. Next question is, why there is residual pain after ankle sprain? How to avoid it, by Mr. Melvin?
Thank you for asking this question because this is the most important part, because when you have an athlete who has an ankle sprain, the risk of getting the second ankle sprain is the previous injury, which means you can never make the risk of recurrent ankle sprain zero. Now coming down to pain, whenever I see an ankle sprain, I try to divide into, okay, what are my anatomical structures here? So if you look around ankle joint, it is not as stable as elbow joint. So the construct is basically on the ligaments. So the residual ankle sprain, so there are bony components to it. There are cartilaginous components to it. There are residual synovitis component of the joint to it. Most importantly, the sensitization component to it. There's a big element of what we broadly call as complex regional pain syndrome. You may or may not see as a complete entity, but a peripheral sensitization does come up in ankle sprain. One of the areas which I find is very commonly involved is the sinus tarsi in the subtalar joint area. That does lead to ankle sprain. Now, if you look at anatomically at the talus, the anterior aspect of the talus is broader than the posterior aspect. So whenever you're having an ankle sprain, to accommodate that ankle sprain, the talus goes, or the foot or the ankle goes into plantar flexion, which brings the narrower posterior aspect of the talus. So there is a glide happening there. So there are multimodal factors of residual pain, but I've just enumerated a few.
Thank you, sir. Next question is, for return to sports after sports injury, which is to opt for, surgical or non-surgical mode of treatment? By Dr. A. Manoj Kumar.
Manoj, I'm not sure which injury are you talking about. When you talk about, so I'm glad that you have not put the word as conservative method, because there is nothing called conservative method here in sports injury. So if it's very straightforward, if there is a fracture of the bone, of course you need to, if it is a displaced fracture, I should say, surgery is required. So the answer, I probably would be able to give you a better answer if you ask me a specific injury, but the real answer is that you will have to look into the injury, what has happened. Soft tissues can heal, like for example, ankle ligaments and all that can go very well without surgery. But again, you first need to probably know what specific injury are we dealing with, and then decide which way to go.
Thank you, sir. Next question is, at what age a kid can start intensive sports which involve elbow activity? By Sujita Paulus.
So again, the word intensive sport is with respect to kids. I think you need to take it as a relative term. Now, there is a term called sports specialization. So there was once a paper, I think probably from US, where they said, if you train for 10,000 hours, you will get an Olympic medal, or you can become an elite athlete, something on those lines. But that went heads down because that led to overuse problems. So in a kid, I always probably say this, and I share this with all my athletes and parents, that adolescents and kids are just not young adults. They are a different entity altogether. They can present with the worst pathology and actually not come up with the symptoms because they don't know. So coming to your question, when you talk about intensive sports with elbow, are you talking about the resistive things or the throwing things, like the pitching? So for the pitching, I mentioned about the risk factors. So there is no specific age, but we talk about not getting them specialized no sooner than say 14 to 15 years, or maybe even 16. There are a few numbers floating around, but again, there is no one age to get that specialization happening. Does that answer your question?
Yes, sir. Yes, sir. Thank you, sir. What lies underneath Sachin Tendulkar's elbow injury? By Dr. Umar Dilibaj.
I don't know because I've never examined him, so I don't know. Well, I think it comes down to overuse and pattern. Athletes like Sachin Tendulkar, I think they work so hard, and despite taking all the best possible actions, they can still have injuries. So it will be a combination of few things, but I really can't comment because I've never examined him. So, but I will take it on board of a common extensor tendinopathy as an elbow injury. So, yeah, sorry, I probably can't answer this question.
No, sir. There was a conspiracy that his bat's weight was more, which might have been provoked for elbow injury. Something like you want to add in that, sir?
Sorry, I missed that.
There was a conspiracy that his bat's weight was too high to create a elbow injury for him.
Yeah, okay.
Sachin, if I may intervene in this, probably it's a very popular injury,
Of
Sachin's
course.
injury. And Dr. Manoj, I think, is trying to put it across about the external risk factors, about Sachin's bat being too heavy would have caused it the over injury apart from the workload they had.
I think now when you talk of athletes at that level, you know, with a heavy bat and all that, theoretically, yes, but I probably would not put the blame on the bat as the cause of his problem. I think it will be a tiny chunk to contribute. Now, if you say, for example, of course, now I'm just correlating it with the tennis. Say if you have a heavy racket, yes, it is a potential reason for overuse injury because you're certainly overloading the tendon more. But I would not expect an athlete at this level not to have trained that much to carry that load. But theoretically, the answer is yes, it has a role to play in just like anything else to play. But I would probably don't think that is the sole reason for the tennis elbow he had.
Thank you, sir. Does the extent of ligament tear vary from person to person if they have similar extent of injury? By Dr. Sahana Manoharan.
Does the extent of ligament tear vary from person to person if they have similar extent of injury? So similar extent of injury by definition would mean anatomical, but if so Hannah, you're asking about whether the mechanism of is the same. If the mechanism is the same, can different athletes have different levels of ligament tears? Answer is yes. If there is an image wise, you find that the ligament is the two different athletes are having same amount of tears on imaging. Can they have different recovery times? Yes, answer is yes. Because again, the same imaging injury or the injury seen on the imaging in different athletes can behave differently. Again, coming to the point that there's a lot more which lies underneath just than the ligament. So both ways, answer to your question is yes.
Thank you so much, sir, for taking our questions with your valuable inputs and suggestions. There are almost 100 questions that are there in the chat box now after your session is being over. Thank you so much for your input, sir. Over to Gresham at Rajma.
It's a pleasure. Thank you.
Sachin, I would like to ask a question. This is
Yeah, why not?
Yeah. I'm having tennis elbow injury, right?
Yeah.
Elbow. In 2012, I was asked by the doctor to have a steroid injection.
Yes.
So before that, they gave me LA. Immediately, anaphylactic shock happened. So even now, I get pain. The pain persists. So what will be the solution? Yeah, I'm in second life now.
Come to Australia. I'll treat you.
Thank you.
Okay. Short answer is,
yeah.
For any tendon problem, corticosteroids are not the solution.
Okay.
Number one, corticosteroids help to control the pain. And as I say to my patients, that they can actually be more detrimental. So in tennis elbow, the evidence says that the corticosteroids can help from 2 weeks to about 2 months. Now, when we talk about tennis elbow, you're talking about tendinopathy here. So tendinopathy is an umbrella term which means tendon problem, right? So it means your strength of the tendon was far less than what you have, the repetitive loads you had through the elbow. So I can't imagine any injection, may it be cortisone, may it be PRP, may it be autologous blood, may it be prolotherapy, or any other sclerosing agent, that it can make your tendon strong. So my advice to you is, yes, sometimes you have to take these injections, but please do not rely on multiple injections, specifically cortisone for the tendons. There is a theoretical risk, at least, that it damages. It is a catabolic medicine. It can affect tenocytes. It can affect their regeneration. All you need to do is a very programmed rehab. I must add here that please do not just focus on the elbow. Trust me, you will be having some issues, or you might have some issues related to shoulder. So all I need you to do is to go back to your physical therapist and say to them, look, I need to progressively load this tendon if they have ruled out other comorbid or co-located injuries around the elbow, plus work on the kinetic chain, which I just mentioned. Your scapular muscles, the thoracic mobility, your trunk, that has to be addressed alongside. And that I'm pretty sure tendons recover. In tennis elbow, the conservative methods have a success rate of about 80 to 85%, and only 10% go to the surgeons. So it's had a great success rate.
Yeah, thank you, Sachin. That was a wonderful answer for me.
Yeah.
Once again, we thank you, and we would like to present a certificate as an appreciation by the organizer.
Oh, that's nice.
Yeah. Kindly receive this certificate for your featured presentation on sports injuries, what really lies underneath. Thank you.
Well, that's really so nice of you guys, and it's long till I have received any certificates, so that's good. Thank you very much.
Yeah, thank you so much, Dr. Sachin, for your elaborate answers for all the questions, and thank you for your wonderful presentation. Meet you soon. Thank you.
My pleasure. Thank you.
Let me introduce the second speaker, Dr. Janine Gray. She is a senior physiotherapist from South Africa with an academic interest in injury prevention. She has done more research on shoulder and lower back injury in sportsmen, especially on cricketers. She currently holds an honorary position of UCT in the Division of Exercise Science and Sports Medicine, Department of Human Biology, Faculty of Health Science. She has got PhD in 2012. Her thesis investigated the contribution of various aspects of biomechanical, physiological, and muscle recruitment factors in the etiology of low back pain in adolescent fast bowlers. She is the consultant for Sri Ramachandra Institute, India. Clinically, her interest includes the shoulder and lumbar spine of adolescents, with the special focus on the prevention and rehabilitation of these sporting injuries. With these few words of introduction, may I now invite Dr. Janine Gray to present her topic on sports injury biomechanics from a rehab perspective. Dr. Janine, screen is yours.
Thank you so much, and thank you for that lovely talk, Dr. Kula. There were some things that were really great to hear because I'm going to reinforce them in my talk as well. So lovely when we get to talk along the same line. So thank you very much. Really enjoyed that talk. Right, so I'm going to speak on one of my passions when it comes to managing injuries in sportsmen, and that is biomechanics. And I'm going to put a disclaimer up front here. A lot of the research that we talk about is very much very scientific, very academic. We know Vicon systems, force plates collect data with high accuracy. When we then use this information to manage athletes, and we then sort of bring it into the clinical sense, the evidence for doing that is much less. So my disclaimer is that there is a lot of clinical license that I'm taking with my interpretation of the biomechanics. And we can discuss that as we go along. So I'm from South Africa. I have been involved with Cricket South Africa in the past as their research consultant. I am honorary lecturer for UCT, so I've continued a lot of research, a lot of it centered around biomechanics and musculoskeletal risk factors of injury. Yeah, and I'm to be found in Cape Town, the not so sunny Cape Town at the moment, but yeah, greetings to you all. So when we just have a look at why we would study biomechanics, from a mechanical perspective, we need to understand how we are going to generate and control movement. How is it that people achieve movements, and how are they different? And what mechanical anatomical factors determine or limit outcomes? And these can be either performance, or they can be packaged as risk factors for injury. And then I think the big question is always, how do we make our movements better? Having been involved in elite sport a bit, you soon come to realize that a 2% increase in performance can win or lose a match or a race for an athlete. And biomechanics is one of those areas that we are looking to optimize. So then if we just go on to look at the problem-solving approach, this is a busy slide and I don't want to go into too much of it. But I think one of the things that I just really want to make a point of here when it comes to a lot of biomechanical studies is that I think we need to ensure that all of our biomechanics investigations are very much performance or injury related as generated by the coach or athletes. I think we need to make sure that there is a big collaboration between the actual sporting environment and the research that's been done, so that we can ensure that all of our biomechanic outputs are actually of value to the sportsman or the coach that is working with a team. One of the first things we have to do when we start investigating biomechanics of a certain area is to actually look and get general information. So what are the basic biomechanics of a throw? And we have been, I have a PhD student who has just completed her PhD looking at throwing in cricketers. And we have found that the throwing that cricketers perform is actually quite different biomechanically to a pitcher, a baseball pitcher. And so we've got to be really careful about basing a lot of our interventions and our strengthening programs on a sport where the overhead nature of the throwing is the same, but the specific biomechanics or the musculoskeletal profile of the athlete may be quite different. So that really are the points I wanted to make with that slide. So I'm going to present some of this talk in two different sports. So we've done some work in running, and I'm going to present a couple of case studies in that area, and then to look at the fast bowling lower back injury and how we use some of the findings of the biomechanics of fast bowling to determine how we treat athletes, particularly once they have an injury. So at UCT, at the Sports Science Institute in Cape Town, we have a running analysis program that we use to look at both performance and injury risk criteria. It relies heavily on clinical interpretation and is certainly not ever, the results never determine exactly what rehab is being done without a clinical investigation. And I think that's a point I'm going to make a couple of times. Very often people find they get results from biomechanical studies and then they immediately institute a strengthening program without a proper evaluation to find out if that muscle is actually weak. And I think we need to make sure that whenever we use biomechanical data, it doesn't replace the clinical investigation that is done at the same time. So if we just look at runners, for instance, we know that the knee is the most injured joint, followed by the lower leg and then the hip. So lower limb biomechanics are obviously something that would be of particular interest, and there's been quite a lot of work that's gone into this, particularly when we look at an injury rate of runners is anywhere between 26 to 92%. We know this just gives you an idea of the most common injuries, patellofemoral pain syndrome being the most common, but all of the injuries below being relevant to the lower limb. Again, my main point of sharing this slide is that the type of pathology experienced by male and female runners is quite different. And I think for this reason, the biomechanics of running needs to investigate both men and women because their biomechanics may well be different, because we know there are a lot of anatomical variation between men and women. And so we do need to see the two groups as separate groups. We can't do too much overinterpretation of biomechanics in one area or one gender or one sport into another group. So we need to be careful when we do that. So some of the things that have been found is that the hip mechanics can be altered. And this is particularly pertinent when they've investigated women athletes or women runners. In particular, they noticed that an increased hip adduction or hip internal rotation is linked to patellofemoral pain. So we have a biomechanical variable that is linked. One of the things that I must just point out, when we did a lot of our reading around this topic in preparing this model of assessment for runners, was that a lot of studies would investigate an injured population and compare them to a non-injured population. And I think we need to be very careful about interpreting risk factors when you compare an injured and uninjured group, because I think pain can alter biomechanics. So what is really important here is to look at the prospective studies. So to look at groups that tested the biomechanics of runners before anyone got injured, and then to track them over time, so that we can actually identify risk factors that could potentially have caused the injury, and not necessarily things that could be the result of the pain or inhibition or the injury itself. Just following on from the previous talk, previous point, sorry, the hip adduction, internal rotation risk factor is often associated with a contralateral hip drop. And this can be due to weakness of glute medius on that side. But the hip drop itself can tighten the ITB and can often be one of the causes of ITB. And sometimes we can actually see it as a compensatory body lean to that side to try and ensure that the balance or the center of gravity remains the same. So it's also been linked to ITB pathology. What is particularly interesting is that we then go and look at other studies. We've found that there is increased hip abductor or glute med activity when we look at activities that involve single leg stability. And the recruitment of hip abductors were found to be delayed or decreased in runners. So when they did the EMG studies, what they'd seen biomechanically was actually confirmed when they went and looked at the recruitment of the hip abductors. And they have found in doing testing of both men and women with patellofemoral pain that they have found decreased strength of the hip abductors. So here you find that your biomechanics are actually speak very nicely to the clinical findings in this group. We've also found, and this is a little bit of repetition, it's a separate study that looked at particularly at female runners, that they had an increased hip abduction, which I've mentioned previously in toe off, a decreased activation of the gluteus medius, so that's a repeat of what we've done previously. But what was also really quite interesting was that we found they found an increased duration of soleus muscle calf activation. And working clinically with some of these patients, we often see this kind of patient where there is an instability around the pelvis, whether it's a weakness of glute med or glute max. These are athletes that present to you and you look at them and they have these really well-developed calves. And, you know, we assume that the lower limb biomechanics are really well, performing really well because the calf muscles look so well developed, but they really are compensating for the proximal girdle muscles that are not working quite well. So we sometimes use that as a little bit of a clue to look higher up along the kinetic chain. But then this is the part that I find really exciting, and this links to the rehabilitation, is that there have been studies which have now looked to improve hip abduction strength. And the exciting thing is that, number one, the intervention did improve hip abduction strength, which is a relief if that was your goal. But most importantly, they improved kinematics. So they actually were able to change the biomechanics by simply strengthening the muscle. And for those of you that work with athletes, or if there are any coaches in the audience, the one thing that you would know that is really hard to change is the biomechanics of an athlete. Very often, I've worked a lot with fast bowlers, that whole delivery stride is happening in less than a second. So for the athlete to consciously make changes takes months and months and months. So to be able to strengthen an athlete and result in good biomechanical changes is a really exciting finding, and something we certainly are looking to investigate more. And then obviously a really good thing was that there was also a decreased pain in the group that had had the strengthening intervention. This is now just a case study. This was one of my runners who had presented with injury, a long history of injury. And really this is one of the graphs that we generate from our running analysis. And what you can see from this is that there is less hip extension on the right side. In fact, they don't really go into hip extension at all. The hip really goes to neutral and doesn't extend into extension. And so based on this case study, we then went and evaluated this athlete. And the glute max of this athlete on the right-hand side was considerably weaker. In fact, we really battled to get this patient to activate the glute max at all. And so here, having done the biomechanical analysis, really helped us problem solve and find out one of the areas that were causing pain, increased force lower down in the kinetic chain. And we were able to make considerable improvements and change the look of the graph, which then also correlated with really nice improvements in her running performance. So just always have to mention glute max. It is the biggest muscle in the body. It is very important for hip extension, weight support, and propulsion. So it is really important in runners and sprinters and athletes that are trying to propel themselves forward. And increasingly, we are finding, and biomechanics has led us here in a number of our athletes, really weak glute max, athletes that are really battling to even activate the glute max in neutral, let alone into extension. And they use a whole lot of compensatory patterns, which include, for example, the erector spinae. And that causes a whole lot of further problems. This case study is one that would show that. This was a 16-year-old female competitive long jumper. In fact, she did triple jump as one of her main events. And she had come to us with a stress fracture on the left L5. And when we assessed her using the prone hip extension test, she had very, very weak hip extensors. She had massive increased ipsilateral erector spinae activity with a massive anterior tilt. And she had a cramping sensation in her hamstring when we got her to do the prone hip extension test. And she said she often complained of cramping in her hamstring. And this biomechanically makes a lot of sense. If you're using your erector spinae to try and drive yourself off your left foot to jump, you are going to push the back into massive extension and put massive loads through the posterior elements of the spine. And so that was one of the reasons that we thought she had developed the stress fracture on the left-hand side. It actually took us quite a long time to get the glute max really well activated. And after her rehabilitation had completed, the thing that was so exciting was that she broke all her personal bests in long jump and triple jump, because now she could utilize the glute max as the main driver of her jump. And so not only had we hopefully taken away the risk factor for the lower back injury, but we'd improved her performance as a really nice side benefit. One of the important things I always tell runners is when we're looking at biomechanics and trying to get a runner to do strengthening, and it's really, they're not a group of athletes that seem to do a lot of strengthening, is just if you have a biomechanical fault that we are seeing on one or two steps in the biomechanics lab, you need to remember that in 1 kilometer, we take on average 1,250 steps. So a 5K run would equate to 6,250 steps. So if your pelvis is tilting, your hip is adducting, you're doing that 6,250 times. And so that is one of the reasons why a lot of these faults develop into a significant overuse injuries, because of the repetition of the activity that is done so often. And then just an aside is having read a couple of studies, to put it in a very broad context, it takes 200 muscles to take a step. So you really don't want a couple of your muscles not to be working. That will just really overload the system and cause major biomechanical faults. So we really do need to make sure that our system is strong and the right muscles are doing the right action. Just one of the points I'm going to make, and I'm going to make it again later with the cricketers, please every runner is an individual. And I think what we are doing too often is reading research papers, looking at the hip adduction and reading this about glute medius. And we simply start instituting glute medius strengthening in hip internal rotators. There are a number of factors that could lead to different, or even the same biomechanical fault happening in runners. So please, nothing replaces the clinical investigation to look at whether the muscle is potentially weak or which muscle is causing the biomechanical fault that you've observed when you've done a biomechanical assessment. So please, every athlete is an individual. Right, so then we're just going to look at the biomechanics of fast bowling and rehabilitation from injury. So really, just to put it into context, this was an area that I've been particularly interested in. We know that lumbar injuries, particularly stress fractures, are one of the most prevalent injuries in cricketers. And we know that one of the most common lumbar injuries is the stress fracture. And it is particularly pertinent in our adolescent population, with some groups showing a 66% incidence of stress fractures in a population of fast bowlers. So really quite a significant injury and potentially catastrophic to a young cricketer's or fast bowler's career. So really, when I go into the biomechanics, we need to understand that the injury is multifactorial. So ground reaction forces, bowling biomechanics are a potential factor, but they are combined with age, workload, motor control, muscle symmetry, muscle strength, and conditioning. And very often it's a balance between the force exerted and the number of cycles performed. So while we discuss the biomechanics, please don't forget the other large number of factors or risk factors that could lead to a stress fracture. And this point just makes it as well. Kinetics and kinematics are one area that we investigate when we're looking at what can overload the tissues of the kinetic chain. So one of the first points I want to make is the ground reaction forces in fast bowlers. They are between 4 to 6 times the body weight, and this is particularly on the front leg. Why we discuss the front leg is because the stress fractures clinically appear more commonly on the left-hand side of a fast bowler's spine. So these forces are 4 times the body weight. I just want to put this into context for you. So if you have a fast bowler who's about 90 kilograms, let's say, and let's say they've got 5 times their body weight going through that front leg, we are looking at 450 kilograms of force that are going to be entering through the foot and need to be dissipated through the body. So these forces are transferred to the body via the kinetic chain. So the previous speaker spoke very much about this, and I think it's really, really important that we acknowledge up front that these ground reaction forces during the delivery stride of bowling are double that of running, and that these forces need to be appropriately dissipated. So how do we do that? The legs and the pelvis and the global core muscles need to be really strong to be able to dissipate these forces and to prevent them directly impacting the integrity of the bone of the lumbar spine. So very much retraining big global muscles, glute max, hamstrings, gastrocs, quadriceps, and start by a simple strengthening, but remembering that we need to continue our rehabilitation into explosive strength. We need to make sure that we can introduce the whole aspect of power training in the lower legs. So one of the things that I assess a lot in my athletes that come to me with stress fractures is the actual strength of their legs as a way of trying to dissipate this ground reaction force. This was a lovely study done looking at, it was an EMG study, looking at the posterior trunk muscles and the recruitment of the various muscles at different stages of the delivery stride. And what you can see here is that, for example, I'm going to pick out the glute medius and glute maximus, were really very active around foot placement. So that would indicate that they would be really well suited to dissipating these ground reaction forces and trying to balance the pelvis on landing. So a really important role during the delivery stride. Similarly, erector spinae, another big global muscle in the body, was also really active near back foot impacts. And this is because it is really important in absorbing the ground reaction forces of back foot impact. But it was also very active post ball release. So that would be very important in it working eccentrically to decelerate the follow through of bowling. So these studies give us a really good insight into not only the ranges that we need to work our athletes, but whether we work them eccentrically or concentrically, and the actual angles of the joint that we put the body in when we are strengthening. So erector spinae is another muscle we need to look at. And Helen Bain's done some lovely work in adolescent fast bowlers and looking at risk factors there. And she found when she studied a group of young adolescents prospectively that those that went on to develop back pain had a reduced lower back extensor endurance. So including tests like our Behring Sorensen, or the picture below is really just a back extension, a timed back extension, are really important when we go to screen athletes to see, our fast bowlers, to see whether they are strong enough. Their erector spinae has the endurance to actually decelerate the body and deal with these high loads. So implications here, rehabilitation must always include an element of erector spinae strengthening. And I think very often clinicians avoid extension training because stress fractures are considered to be, one of the mechanisms is extension and lateral flexion. And so they've avoided strengthening. And I think we do our patients a big disservice if we do this. Here's another point that I often make is, don't assume that bowling makes relevant muscles strong. I've evaluated a number of athletes and amazed at the dysfunction and even sometimes the lack of activations of big global muscles, but yet they still manage to perform adequately, although injury is usually what stops them. And then again, that just makes my lower point. Please make sure that they're activated properly and that the right motor patterns are being used. And we can look at things like the prone hip extension test, give us an idea of whether the erector spinae is trying to do the work of the glute max and the glute max is weak. So we can use a whole lot of different clinical tests to investigate this. Sorry, my screen has just stuck. There we go. Okay, so when we look at the bowling biomechanics, there's been an interesting move over the years in bowling biomechanics and factors that have been associated with injury. Very early on, we looked at the counter rotation of the shoulders after back foot impact. So that's the movement of the shoulders away from the batsman. It's almost like a wind up prior to delivery. And the whole mixed action was born because they found that if there was an increase in the amount of counter rotation of the shoulders away, that it was associated with pathology. More recently, we seem to be linking active lateral flexion to the non-dominant side of ball release with lumbar pathology. So if you look at the picture on the left-hand side, you can see that that athlete is falling into lateral flexion towards the non-dominant side quite significantly. And if these angles become too large, then we know that they become at risk of developing a stress fracture. And it makes sense because into lateral flexion, the facet joints on that side would be compressed. And that can cause a turning moment of the neural arch, which can lead to a stress reaction. So combined with some other findings, we find that loads are greatest immediately after front foot impact. So that is front foot impact is when the non-dominant foot strikes, all these great ground reaction forces going down. And there was a significant chance of injury if you positioned at the end of range. So for instance, more in lateral flexion at this point. Craig Ranson did a lovely study where he found that athletes, fast bowlers, actually used an extreme range of lateral flexion when they're bowled, compared to just a active lateral flexion measurement prior to the bowling analysis. In fact, they almost used about 150% of available range. So we need to be aware that we need to deal with a lot of these loads. And we know that if we do a co-contraction strategy, it may assist in dissipating forces. So co-contraction between an agonist and an antagonist muscle. So co-contraction can also assist in the deceleration of movements with high torque. So for instance, we want that whole internal rotation followed through after ball release to be adequately decelerated. And I'm going to discuss what muscles need to be done here. So I presented this paper at the World Cup conference in 2015. We did an EMG study during the bowling delivery, and we found in individuals that had back pain that there was decreased internal oblique activity at impact. So in the non-injured bowlers, both the internal and external oblique contracted together at the points of impact. In bowlers that were injured, the internal oblique no longer acted to try and assist in dissipating these forces by a co-contraction strategy. There was also a decreased external oblique activity between back and front foot impact, which would indicate that the rotation torque generated by the internal oblique on the non-dominant side was unchecked. And this may actually threaten spinal stability and control. Helen Bain, just as another study that she did, where she found that the lumbar shear forces, and we know the lumbar spine does not enjoy shear forces, had forces that were 40 to 50 times greater than treadmill running. So we are dealing with massive forces when we are dealing with our fast bowlers. The peak lumbar moments were 25% greater in the transverse plane rotation and 100% greater for lateral flexion. And really what that says to me as a clinician is that I have to have my trunk and leg strength of my athletes, and strength and power absolutely fine-tuned to be able to dissipate these forces that are involved. Clinical implications, please. Very importantly, and I haven't discussed it at length, segmental rehabilitation of the deep stabilizers has to happen so that you have a strong foundation to build the strength on top of. So although I haven't spoken about it much in this talk, please, it's absolutely vital. Very important to retrain trunk rotation and lateral flexion to both sides. We know that there are marked asymmetries in this group, and please ensure that the correct movement patterns are used. Recently have been rehabbing an elite fast bowler, and he had lower back pain for a significant period of time. And when he does rotation, he simply does thoracic rotation. He keeps his lumbar spine fixed. So we've had to do a lot of motor pattern retraining to actually improve that range of movement, to allow him to again use his lumbar spine to generate the force. Just a couple of points I want to make here. There obviously are increased loads in bowlers that have increased bowling speed and a more extended knee angle. But the problem with that finding is that bowling speed is a performance priority in fast bowlers, and a more extended knee position is associated with faster bowling speeds. So what is causing injury is actually really important for performance. So we have to, as clinicians, find a way to balance it, and we do that by adequate muscle activation and strengthening. The implications for the knee angle, we need to retrain quadricep strength, especially eccentric control, And once we've done that, we need explosive power once we've got a stable strength base. This was an elite fast bowler we looked at. He landed, his knee angle at front foot contact was a really nice 13 degrees when he landed. But by the time he got to ball release, his knee had collapsed to report 50 degrees. And when we investigated and chatted more, he'd had a long-standing knee injury on that side. And it was actually decreasing his performance because he was now, a knee was collapsing. So we used, we did a lot of intervention there. We improved the knee pain and performance at the same time. This is another point just to support the fact that a single leg stance can identify a potential risk factor for injury. They found in fast bowlers that developed lower back pain, they had a marked increase in the knee valgus on that side. So we can use them as screening tools, and then we go and find the weak muscle and we strengthen it. So we need to look at things like eccentric strength of our contralateral quadrumborum, to decelerate in the follow through, strengthening of glute medius, strengthening of rotation and lateral flexion. And really what this slide just demarcates is the top row of athletes are really more, it's a lot of what I find a lot of our elite athletes doing. They really are working in a single plane, and really how we've changed our rehab for our fast bowlers a lot is to do rotation and lateral flexion type of exercises. You can load it with weights, they can do very strong strengthening, but in the right planes of movement. And I think I've spoken to this. We need to make sure that local stabilizers are activated so that there's good segmental control, that we're not loading one joint more than others. Our global movers need to be activated, strong, and have endurance. And we need to make sure that we're using the correct pattern. So quickly, as I finish off, when we're looking at an athlete, there are 3 areas that we look at with regards to lumbar stability: the deep segmental stability, the lumbar pelvic stability, and pelvic femoral stability. And there are a number of tests we can do for the different areas, but the important point is that don't treat all of them, test all of them and find out which parts of the system are dysfunctional, which muscles are causing the dysfunction, and treat them specifically. And then add things like, as I've mentioned previously, leg strengthening. Proprioception is invaluable. Kinetic chain, which supports what the speaker earlier this morning said. And then also upper limb coordination. We know that I've worked with Bob Woolmer at one stage, and he always spoke about the windmill. Your delivery arm is moves as strong and fast and in a good line, dependent on what your non-dominant arm does. So we do a lot of training in that area, and we can use whatever. I love shadow boxing for that, but there are a number of different tools that you can use. So make sure that you retrain the whole kinetic chain. And as I mentioned with the runner, treat every fast bowler as an individual. We don't ever hand out standard rehabilitation protocols for our athletes. Everybody every athlete that I treat, every fast bowler that I treat has a different clinical presentation, different weaknesses, different shortnesses, that's flexibility issues. And we need to make sure we identify them specifically. Otherwise, your rehabilitation won't be successful. Yeah, and I just finish off with the slide. We have put together some preventative exercise based on a number of the findings that we have in the literature to try and preempt some of these things happening and to improve the strengthening of our cricketers. Great, and that's it from me.
Thank you very much, Janan, for your wonderful presentation. And let me ask Dr. Manoj from Tamil Nadu Physical Education and Sports University for the question answer part.
presentation. You have a good clear cut about the components of analysis as well as rehabilitation of a sports injury in terms of in relevance with the sports, fast bowling as well as cricket area. So due to time constraints, we are limited to have only 4 questions from the audience. The first question is, how does eccentric loading in contrast with concentric loading help in injury prevention as well as rehabilitation? From Dr. K.B. Srinivasan.
Okay, so eccentric loading is really important when we consider it as an aspect of being able to decelerate a movement. So if you just imagine the body that is moving, so moving forward into forward flexion, we've got rectus, we've got our obliques drawing the movement, and they're contracting concentrically towards ball release. And then as we move into follow through, we need to decelerate that forward movement. So our rectus spinae, for instance, has to work while it is lengthening. So eccentric loading is very important in decelerating a movement. We found it a lot in throwing. So we work a lot on, and a lot of coaches spend a lot of time strengthening the internal rotation of throwing and concentric strengthening of it, because it works concentrically when we throw. But the external rotators actually decelerate the throw. And that deceleration needs to be controlled. Otherwise, you're going to have a lot of translation of your humeral head. And it is an eccentric muscle control, an eccentric muscle action that is actually going to do that. With regards to prevention, there's been a lot of talk, and there have been a number of studies proposing that eccentric loading may be effective. I know it's particularly pertinent around the tendinopathies and stuff, but I would never do one in exclusion to the other. So I would always make sure that we train concentrically and eccentrically together to prevent injury.
Thank you, ma'am. What are the biomechanical factors to be noted before buying a good running shoes? By Dr. Ailili Bushman.
Okay, that's a really tough question. Okay, so obviously a running shoe is it's very much speaking about the biomechanics of the foot. And we really do battle to assess pronation well in a running shoe, because obviously the foot moves within the shoe. Yeah, it's not quite as easy as looking at the hips and stuff like that. But we would obviously need to look at whether somebody is a pronator or a supinator, and choose a shoe accordingly. There's been some work suggesting that perhaps we don't need to be as specific in people that have, if somebody has been a pronator, they've been their pronator all the time. So do they actually need an anti-pronation shoe? Is not pronation part of their natural biomechanics? I'm not sure, the jury's still out on that for myself, but really I would look to, particularly in my athletes that come to me with clinical issues in their lower limb, if I'm noting marked pronation, I would then suggest an anti-pronation shoe for certainly for their recovery from injury.
Thank you, ma'am. Will knock knee allow a swimmer to excel or hinder in his performance? By Kuldeep Singh.
That's a very good question, and I actually don't know that I have the answer. I think I see a lot of athletes with knock knees, and I certainly don't think it's ever hindered their performance. I think knock knees, particularly knock knees, if they've had knock knees their whole lives, we're finding more and more that the static biomechanical factors are not as linked to the injury as the the dynamic movement. So they're actually looking to see whether the knee goes into more of an avalgus, into a valgus or an adduction position during movement. That's more related. I don't think knock knees are going to affect a swimmer. I certainly think maybe they might even be beneficial. I'm thinking of a water polo player because they do that egg beater kick. It might, a breaststroker, it may actually cause a plica injury. I would potentially, but I haven't seen a lot of swimmers recently. But when I was, I can't ever say that knock knees was something that I would have felt would hinder their performance.
Thank you, ma'am. Last question. What are the adverse forces acting on toe of an athlete?
Okay, so at toe off, you've obviously got the propulsive forces that are happening, and so the ground reaction forces have obviously, they enter the foot at the heel down or the toe down, depending on which has impacted first. But at toe off, we obviously then have more of the propulsive forces. We also have a lot of the braking forces will have more of an impact there. And so this is where adverse forces, this is where I would be concerned, for example, if somebody doesn't have a strong glute max or isn't actually using hip extension, that they would require more propulsion through the calf. And that may cause adverse effects and loading on the lower limb kinematics. So I'm not sure if that answers your question. When on heel strike or toe strike, depending on whether they're a heel striker or a forefoot striker, there we look more at the impact rate, and there that is being very strongly linked to injury. So if they have a high impact rate, then we are concerned about injury risk. Toe off, I think there you're looking a lot more at the forward propulsion and whether that is being appropriately performed. And in this case, it would be very much by the muscle system of the body.
Thank you, Dr. Janendra. Now over to webinar director, Dr. Vaselina, ma'am.
Yeah, that was a great session for us, Janan. And I would like to say that for you as well, to the viewers, and our university, Tamil Nadu Physical Education and Sports University, is working along with the CLRI, Central Leather Institute, Chennai, for designing and developing athletic shoe for the first time in India. That's a great news for everybody, and we are working towards it.
Great, well done.
Okay, on behalf of the organizers, we would like to present a certificate to you for a wonderful presentation today, and we had enjoyed your session, and that was wonderful. Thank you.
Great, thank you. It's always a pleasure.
Yeah, please receive this certificate.
Thank you very much.
Thank you. Bye-bye.
Bye-bye.
Yeah, let me go to the next part is feedback from the viewers. On behalf of all the viewers present, may now invite Professor Shenbavalli, Principal Mother Teresa College of Physical Education, Pudukkottai, for her feedback on behalf of the viewers. Dr. Shenbavalli.
Thank you, Dr. Grace Serena. I am Dr. A. Shenbavalli, working as principal in Mother Teresa College of Physical Education, which is affiliated to Tamil Nadu Physical Education and Sports University. On behalf of the participants, I express my views as feedback on the 2 days international webinar on sports science organized by the Tamil Nadu Physical Education Sports University in coordination with the Center for Sports Science and Ramachandra Institute of Higher Education and Research under the aegis of Indian Association of Sports Medicine. And Tamil Nadu Physical Education and Sports University is a fast developing institute in the field. That is, it is taking new strides in the field of sports. And it is collaborating with the new and the leading institutes like CSS and IASM, that thus making the university moving forward in the right direction under the able guidance of Dr. Sheila Stephen, the present Vice Chancellor. Yesterday, the first speaker, Professor Mahendran, he spoke about the probiotics and the potential benefits about the athletes for maintaining health, enhance immune system, and reduce upper respiratory tract infection, etc. And it was really a delicious one. And he also explained that a lot of opportunities are there for these probiotics researchers, and it is good information for the upcoming researchers. Next person, Mr. Andrew Gray from South Africa. He talked about the science of high performance as a holistic approach in 3 dimensions, such as coaching science, exercise science, and medical science. It's a very informative and very good session. Today, Dr. Chachin Kullat, as a medical professional, he explained the different sports injuries occurring in various sports in an elaborative way. It was very interesting. And next person, Madam Dr. Janine Gray, talked about the occurrence of injury in various parts and how it should be treated, clinical implications, and rehabilitation in a detailed manner. All the 4 speakers, presentation, interaction, sharing their views, and answering for the questions raised by the viewers were all excellent. And we all painfully aware of the insurgence of COVID-19 pandemic, which created unprecedented crisis. More than 5 million people are affected throughout the world, leaving lakhs of people are dead. The imposition of curfew and lockdown, normal routine life is affected, leading to economic and educational breakdown. As per the sports activities are concerned, everything becomes standstill. Stands cancelled or postponed, as in other industries. Sports activities are also seriously affected. During this lockdown period, organization of this webinar is of immense value to all the academicians, practicing managers, coaches, athletes, players, scholars, and students alike. We are very grateful to the Vice Chancellor, Dr. Sheila Stephen, and Professor Jaspal Singh Sandhu, IASM, for their effort and initiative in organizing this webinar. We also appreciate Dr. V. Gobinath, Registrar, Tamil Nadu Physical Education and Sports University, and Professor R. Mugam, Director, IASM, for having chaired the meeting and provided excellent guideship for the participants. We also feel happy in having Dr. Grace Helena and Dr. A. Tyagarajan as directors, who fine-tuned the activities of the webinar with a neat execution. We further congratulate Dr. Manoj and Dr. Prakash for their interest and involvement in the activities of the webinar, such as welcoming and introducing the chief guest speakers, guest speakers, put by the viewers, issuing certificates, delivering in a graceful manner. We once again appreciate Dr. Grace Helena and Dr. Manoj, who are the boon to the university for their amazing work. We also thankful to Dr. Uma Diliraj, the exercise physiologist, who acted as a technical coordinator and host of Zoom meeting for her neat and wonderful job. Once again, I thank all the organizers of this international webinar for giving me this opportunity. Thank you, one and all. Thank you.
Thank you, ma'am, for your excellent response. Thank you so much. And we enjoyed your speech. Now, on behalf of the viewers, we would like to present a participation certificate to you. Kindly accept the same.
Thank you.
Thank you, ma'am. I would like to introduce Dr. Tyagarajan. And now, before madam comes in, so Dr. Tyagarajan is a director for our webinar now. Along with me, Dr. Tyagarajan is an associate professor, Department of Arthroscopy and Sports Medicine, Center for Sports Science, Sri Ramachandra Institute of Higher Education and Research. He is the first sports medicine doctor in India to have qualified with the Medical Council of India recognized MD sports medicine degree. He additionally has specialized in physical medicine and rehabilitation. He is my co-director for this international webinar. May I now invite Dr. Tyagarajan to introduce our Honorable Vice Chancellor. She is the dynamic Vice Chancellor of our university, Dr. Sheila Stephen, and then requesting her for the valedictory address. Dr. Tyagarajan, please.
Thank you very much, Dr. Grace, for your very liberal prices. And it's indeed a honor and proud privilege to introduce a great Vice Chancellor of the great university, Tamil Nadu Sports University, Physical Education Sports University. Dr. Sheila Stephen, she has got 40 years of service in the field of physical education, sports, as various capacities. And she is a true all-rounder. She has specialized in so many sports, including badminton, basketball, and also a very academically oriented person into sports psychology, research, statistics, and biomechanics. And she has trained extensively in abroad, also in USA and London. She has presented papers in various conferences throughout Asia, Europe, and represented the university in various sports also, including ball badminton, tennis, cricket, and table tennis also. She was a national referee for basketball, and academically she has presented over 85 papers in national and international conferences, authored 3 books, chapters, and over 175 articles has been published by her. She also has additional assignment as the executive member of the Asian Association of Sports Management, and she represents the syndicate of TNPSU, and she is the NAC assessor, and she's also into the boards of University Grants Commission, and she's been the executive committee member of 12 universities, and she's got the best principal award from the AIACHE, and has got a best paper presenter award also from the Asian Association of Sports Management. And she's got various national awards, 6 national awards also. So it's indeed a pleasure to introduce the illustrious Vice Chancellor of the Tamil Nadu Sports and Physical Education University, Dr. Sheila Stephen. Ma'am.
Hello. Thank you for the wonderful, nice words of introduction. I think who is sharing the screen? Mr. Manoj, could you share the screen? I think there is an. Is it okay?
Yes, ma'am. Go ahead.
Am I with the audio also, video, both?
Yeah.
Okay. Yeah. It's really a very wonderful occasion that we come to a common platform, meeting one another because of this wonderful technology we have. I'm so happy for team work, and I congratulate all the participants, all the speakers. There is a pooling of mind. And
ஒண்ணுமே கேட்கல அவங்க பேசுறது. கேக்குதா உங்களுக்கு?
Good, unmute. Is it right? Is it clear?
It's not clear,
Is it
ma'am.
clear?
Clear, ma'am, please.
So many messages are coming. There is no sounds and network and all that. Am I?
Now it's audible.
I said, okay. Okay. I just go ahead. I'll quickly complete because I have been given only just 5 minutes to go. This is one of the wonderful plays, the water body, which we have in our university. And since we have this water resources, we thought we'll go for the adventurous sports also. Next, please. I think I need to share the screen. Something is going on. Yeah, this is about our academic and administrative building. And we have the wonderful library. This is the inside of the library. Our library seems to be a very strengthened library with all e-resources, and people, the researchers can really find a wonderful, useful material here in our library. This is the inside of our library. And we have the indoor auditorium coming up, and you can see lots of facilities have been given. This is the inside of, next one, please. This is inside of, next one, please. The indoor stadium where we can have all sporting facilities. This is the ground. And as you see, the velodrome also is wonderful, unique. Hello. Velodrome also is a very successful and a very unique facility which has been developed by Sports Development Authority of Tamil Nadu. This is a play field which is nicely bordered with a lake. Next, please. Next, please. And we have, as usual, every university or any university will have a sporting facility like basketball court, field hockey, and a cricket ground. And next, please. And we have, this is a very unique seminar conference hall, and the yoga classes happening in a wonderful, pretty bigger building. And this has been used very positively by everybody. Next, please. And we have established, as I told you, we have established lots of laboratories. I don't know, 10 laboratories with wonderful equipments are established because it's a sports university. As I told you earlier, we are also giving lots of scientific support to the performers. And this is all about the, next please, the labs. And then this is also some lab equipments. And next please. And we have lots of facilities for the students to stay in because most of the students are here with physical education. So we have wonderful hostels. There is one hostel for women and one for men, and we have a sports hostel. One more hostel coming up with the 400 beds, which also will be used for the high-level performers. And this is another unique facility we are trying to make. We are trying to have the horse riding academy coming to our institution. And this is a greenhouse. So with all such facilities, this university is growing with all unique courses like MTech Sports Technology, MSc Exercise Physiology, MSc Sports Biomechanics, and we are trying to contribute very well to the high-level performance. We are taking off well, and we are also helping everybody on research, infrastructure facilities, and laboratory. And here, we are trying to establish the Center of Excellence. So first comes the Human Performance Lab Biomechanics, which has been taken lots of effort by Dr. Rajini Kumar. And with the help of the government, we have established a Sports Biomechanics Laboratory. And 2 more academies are supposed to come, the Table Tennis Academy and the Badminton Academy. This is the next one is the inner view of the Biomechanics Lab. Dear audience, as we stand in an Industry 4 era, let's see, we are trying to use the potential of the Industry 4, and we are in the world of 4th industrial revolution. So there are lots of smart technology which could be used for the development of performers. in assessment, evaluation, and developing. So the next slide, we have how we make out the basic analysis, the movement analysis of the players. So even when we start teaching a skill, the movement should be analyzed, the mistake should be corrected. Even if he's a beginner and novice, who should be given lots of biomechanical input, so that even when he goes for maintaining equilibrium, he should lower the center of gravity and all those things. So it is not only for the high level performance, it's for the teaching a skill, technique, other things. At the left, you have the analysis of Usain current world record. Sir, and the first line you see the seconds and the steps and the meters and the meter per hour. So this is how each and every one side is the starting, and the second is his running style. The third one is the finishing. So each and every second is so important, and the movement has to be analyzed promptly with taking considering the force, the speed, the acceleration, linear movement, etc., etc. So this is going to be the right side. You see the inner view of the biomechanics lab, which you're going to have. Um, and the next slide talks about the network of machines, how it is being digitally connected, and how it is going to measure all the parameters which are much more useful to contributing significantly to the performance. The IR camera, the force plates, the electromyograph, the speed gun, the isokinetic machine, the 3D movement analyzer, the biofeedback machine, and the software and the MATLAB. So these are all the machines which we normally use to visualize, to capture, the electrically find out the electrical potential or activity. Here there's a small example of the body mechanic of an athlete on the charting block. Look at how many machines have been linked with it to, they are integrated to find out the movement of the individual, basically through body mechanics. And the next slide is the 3D human and sports motion analysis. I could listen to the previous speaker who was speaking very deeply on this motion analysis. So this is how we get the knowledge, basic knowledge about the human performance, how he runs, the linear movement of the body, the swing of the arm. All these simple aspects are so significant in carrying out the performance of an individual. So finally, you have the electromyograph. The electromyograph is the instrument. The electromyogram is the record of the electrical activity, which can really expose the electrical activity of a muscle. And some more, next please. We have one more slide, I think. This is a force plate. This is a force plate which measures um, the force embedded on that, and based on that the acceleration and the velocity of the run and the takeoff, all those, for all those movements, the force plate is much more used in the activity. And we have the speed gun, and you could see the force wave and the speed gun, and the next one. And the next one is the isokinetic machine. And the next slide, you could see the IR cameras. Next, this is how we are going to get ready with the human performance analysis. And in one slide, you could see how the instruments are digitally connected. And in one area, you'll be able to identify the analysis, the data collection, how it has been evaluated, and this has been tested, and it will be improved, taking care of all the mistakes what the performer is having. So with this small basic idea which has been throwing light on our laboratory, we come to an end, and I want all of your contribution and help to our university. You can come here and learn as well as help us to grow more and more. Thank you. This is the lab, and thank you so much for listening.
Thank you so much, ma'am. It was indeed a great pleasure we had, and it was a wonderful valedictory address. And before going to the vote of thanks, I would like to thank you personally for coming over here and giving your valuable talk for the viewers as well as for all the presenters over here from South Africa and Australia and so on and so forth. Thank you so much. Now may I invite Dr. Prakash for a vote of thanks. Dr. Prakash is the coordinator, one of the coordinator for this webinar. He is from CSS Ramachandra Institute. May now invite him.
Am I audible, ma'am?
Yeah, you can go ahead.
So it was a great international webinar. It was an academic feast for all of us. I'm honored to deliver this vote of thanks on behalf of the organizers. Firstly, I have to sarcastically thank the pandemic for bringing us all together from various parts of the world under the premise of physical education. Having said that, education makes everyone a winner, the learner as well as the person who's willing to learn. Our sincere gratitude to both this uniquely wonderful institution for bringing us all together in this exceptional collaborative effort. The Tamil Nadu Physical Education and Sports University, the Center for Sports Science, and Sri Ramachandra Institute of Higher Education and Research, as well as the Indian Association of Sports Medicine. My sincere gratitude to our inspiring patrons, Sri Venkatachalam, the Chancellor of Sri Ramachandra Institute of Higher Education and Research. And thanks so much, Madam Vice Chancellor, Dr. Sheila Stephen, for your wonderful valedictory address. We are so much inspired that much of work is going in for athletes, especially sports science in Tamil Nadu. And also, I would like to thank Dr. Jaspal Singh Sandhu, the previous president of Indian Association of Sports Medicine, for his opening remarks. I would like to thank the legendary course chairman, Professor Armugan, the director of Center for Sports Science, and Dr. Gopinath, the registrar of Tamil Nadu Physical Education and Sports University, for their constant source of guidance and support. And there is no such webinar is possible without the educated and resourceful faculty. Professor Mahendran Appukutti from Malaysia got his insights on sports nutrition. Mr. Andrew Gray for excellent presentation on holistic approach to athletic training. Dr. Sachin Kular making us understand what really is underneath sports injuries. Dr. Janan Gray beautifully gave an overview of sports injury biomechanics. Thank you. Sincere thanks to all these faculties for making this possible. And this wouldn't have been possible without this enthusiastic organizing team headed by Professor Grace Helena and Dr. Tyagarajan. Thank you, sir, and thank you, madam, for this wonderful effort. And from ground up, these two are given their hard work, and they are the real show masters. Thank you, Dr. Manoj and Dr. Uma. And thanks to Dr. Vikram and Dr. Harish for helping us in sorting out these questions. I sincerely thank all the staff and faculty, as well as the support staff from both these institutions, and to the internet and digital platforms, Zoom and YouTube, for making online education easily possible at times of difficulties. Finally, our most enthusiastic participants who have joined us in thousands for being a bloom of enthusiasm to learn all they can from this truly international symposium. Thank you, one and all.
Thank you, Dr. Prakash, for your wonderful words. Thank you. And once again, I thank you very much. And as one of the director of this webinar, I would like to thank again our Vice Chancellor and other core members of this webinar, and those who have graced this occasion for both the days. And I thank all the viewers for your participation. I thank my team members from both the institutions. Once again, I thank you all. And it's a kind attention to all the viewers. The feedback form will be sent to you all in the group. Make a note, please. The feedback form will be sent to you all in the group, and please fill it up and submit it for getting your certificates. Those who have registered and attended the webinar will get the certificate, and I request you all to wait for minimum 1 day and maximum of 3 days to get your certificates. I repeat, please wait for minimum of 1 day and maximum of 3 days to get your certificates after filling up your feedback form and submitting it. Thank you so much once again, all the viewers and my team members. Thank you so much.
Thank you, Dr. Grace, for gracefully conducting the whole show. So when it came to international, we thought of a special thing. We had 2 international speakers from South Africa who have plenty of experience in India at CSS and other parts of India, and 2 Indians who have settled in Malaysia and Australia. So they have Indian as well as international experience. So together we have brought them here, and I think it has been a very fantastic and useful webinar. And thanks so much for the Tamil Nadu Physical Education and Sports University for the wonderful work. Looking forward to more such collaborations. Thank you, one and all.
Definitely, sir. Thank you very much for your words. Yeah. Thank you. Well done, everybody.